Let's shine by seeing the best in all of us and by treating you here, right in your hometown. Let's look out for each other. Let's stay healthy. Let's shine together.
Hi, I'm Sherry Harlan, program host for Let's Talk Together. And today we have joining us is Amy Mullin and Annie Duke from Reid Endocrinology. And we are going to discuss advancements in diabetes medications. And welcome, ladies.
Thank you.
Thank you.
And before we get started, we're going to find out what you did previously and what brought you to Reid Endocrinology, and we're going to start with you, Annie.
Okay. I started as a registered nurse back in 2012 with Reid Hospital. My background was critical care, focusing on the open heart patients that we had. And then from there, I advanced my degree to becoming a family nurse practitioner. And I started with the hospitalist group with Reid, and I was there for several years and then transitioned to outpatient with endocrinology. And I've been with our endocrinology department for almost 2.5 years now.
Great. And Amy?
Yes, I joined Reid back in 1997, so that started my healthcare career. I graduated in 2000 with my registered nurse license, and then I went back to school after my kids graduated to become a family nurse practitioner in 2020. What attracted me to Reid Endocrinology, as I was very, very fortunate during my clinicals to spend time with Dr. Crutchman and Natalie King, both of our other providers in the office that are absolutely amazing, very passionate about diabetes, and that really attracted me into endocrinology.
Oh, great. Yeah. Well, we're very thankful to have you both on the Reid team.
Thank you.
Thank you.
Let's just do a quick overview. What is diabetes?
Well, diabetes is, we have different types of diabetes. Typically what you're going to hear is type 1 and type 2 is probably the most common. Type 2 is generally thought of as could be caused by more of lifestyle, where there could be a lot of different things going on that can lead to the progression to type 2 diabetes, where the pancreas is just not able to keep up with the demands of the insulin production to keep blood sugars within range. That can be seen with with our population that deals with weight gain and obesity, heart disease, insulin resistance. Type 1 diabetes is an autoimmune condition where the body actually attacks the pancreas and slows the production of the beta cell production that makes insulin to the point where the body is just not able to make insulin on its own. And then there's other things where we have secondary diabetes that can be caused by things that can injure the pancreas, and that can cause that beta cell production to be damaged, leading to having to be treated for diabetes. And diabetes is where your blood sugars, with how our body responds, our insulin production will manage our sugars within range. But if it's not able to do that, then that's where we need to start medical therapies to help the body keep blood sugar in range.
And I've also, another thing we've heard a lot more in the news has been gestational diabetes.
Sure, yeah, and gestational diabetes occurs during pregnancy, and if somebody's diagnosed with gestational diabetes, it's usually screened for around that 28-week during their pregnancy to see if they have an impaired fasting or impaired glucose response. If that is found, then treatment would be started during the rest of the pregnancy. It doesn't always indicate that the person's going to need lifelong treatment for diabetes, but just during that setting, maybe during pregnancies.
Okay. Then I was reading where over 133 million people have diabetes or pre-diabetes.
Yes, it's very prevalent. And as both Amy and I have experienced in our careers, being, working as registered nurses and to the endocrinology, most of our patients have always had, or a lot of our patients have had diabetes. It's very common in what we treat for in our office as well.
Okay. What recent advancements have been made in medicine for diabetes?
There has been a lot of cool things with diabetes management over the years, and technology just continues to get better and better. The one thing that has been released recently is a screening tool that we have for patients that could be at increased risk for developing type 1 diabetes. These would be patients that we see that have a family member, a close family member that have been diagnosed with type 1. But we have an ability to do blood tests to see if they're at risk for this, and then treatment can be provided to delay the onset of having to start insulin therapy. And that's just recently been released for type 1. Outside of that, we have a lot of tools that help us monitor blood sugars, what we call our continuous glucose monitoring systems, where somebody can wear a sensor, and depending on what type of sensor it is, it's generally 10 to 14 day wear, and that while they're wearing the sensor, we'll check their sugar the entire time. So it gives us a lot of insight to our body and what our body's doing and how our sugars fluctuate with that. Outside of the patient having the benefit of that, from a provider standpoint, we get to see that, and we can fine-tune their medication regimen behind what's going on in their body throughout the day. And we have insulin pump, so insulin delivering systems where somebody can use a sensor and the sensor can communicate to the pump, and it works as a closed loop system, kind of like an artificial pancreas, closest algorithm that we have. And then outside of that, we have the ability to do insulin patches that offer the fast-acting insulin as well as the basal insulin, where somebody can wear it either for 24 hours up to 3 days, depending on what device. So a lot of cool stuff that we have on the market right now.
And I wanted to clarify on when people see you.
Yeah.
So are most the people, when they come to you, they've been referred by a primary care physician?
Absolutely. We do accept referrals from primary care physicians. Sometimes they've been newly diagnosed. Sometimes they've been through a hospital admission or even an ER visit with a high blood sugar.
And that's something that we try to educate our audience to, making sure first that you have your primary care physician who would notice something was different. And so, worst case scenario, can you give an example of the person either was newly diagnosed or just had no idea, no doctor, and then and by the time they get to you, often it's a pretty critical case.
Yeah, so sometimes patients may have had, unfortunately, a complication from their diabetes, whether it be like cardiovascular disease, which is one of the #1 complications we have from diabetes. So maybe they came in with a heart attack, and as they came in with a heart attack and they've done some kind of open heart surgery, they found these now elevated blood sugars, and they are not resolving. They are likely been undiagnosed for many years. And then we would see them as an emergent appointment to try to get therapy on them to make sure that we decrease their risk of future complications.
So I always like to say we want you to, for people that have regular visits, so $100 problem doesn't become $100,000.
Right, absolutely. Yes. Please come see us.
Correct.
I know you had talked about advancements in diabetes recently, and Annie did talk about a lot of the therapies and treatments that we have available for type 1 diabetes, which when you have type 1, you don't produce insulin. So really insulin therapy is very important to be able to maintain those blood sugars in a good control range. Type 2 diabetes, your pancreas is still making insulin. So then we have to look at ways the pancreas we can help through medicines. And recently, in around 2005, they came out with a new class of medicines called GLP-1s. It was by ADA that was first FDA approved at that time. It was a twice daily injection. It's an endocrine hormone, so it's a gut hormone that you naturally already have. Recently, you've seen more televised information about these because in about 2014, they came out with once weekly injections, which is very attractive to manage diabetes. And these GLP medicines work very strongly to help regulate blood sugars, but what they do is allow the pancreas to release extra insulin to manage those high blood sugar numbers. They're very convenient for patients because it's something that you have to think about once a week. And it's also pretty cost effective if your insurance covers them. Some of the names that you may hear on these GLP medicines are semaglutide, which is Ozempic. That's pretty popular right now. Also, another one is Wegovy, which is branded for weight management, which we also do in the office. So those have been pretty popular since 2017 when we came out with those once weekly medicines. Another GIP medicine is called tirzepatide, which is Mounjaro. It was just released last year, I think. Was it last year? And because one of the side effects of it is weight management, we do see a lot of uptake of that medicine right now, which presents, a lot of opportunity for us to take care of patients in a wonderful way.
Also, do you get a lot of questions for people that because they now are starting to get used to seeing their different medications advertised?
Sure, yeah.
So do you have a lot more inquiries?
Oh, absolutely. We have a lot of uptake with inquiries about different medicines and what they treat and what they don't treat. We also have, restrictions from insurance companies, what they're willing to pay for. So that's one of the struggles that we see as providers. Just because we feel a medicine may be beneficial for you doesn't mean that your insurance is going to provide coverage for it. Some of the other medicines that just came out back in 2014 are the SGLT2 category medicines. These are oral medicines that help when your blood sugar is high, the extra blood sugar comes out through your urine. So with those medicines, you see if your blood sugar gets above 180, the extra doesn't even filter through your kidneys. So they found that those type of medicines not only help with your blood sugars, but they also help protect your kidneys, which again is another complication we can see from diabetes is kidney failure. And they also are cardioprotective, so they help your heart. So of course in the office, if we ever have any patients that have complications, as far as heart failure or cardiac disease, we're reaching for these medicines if we're able to.
A lot of bang for your buck when you're protecting the heart, the kidneys, and blood sugar control.
Right. And then we had the addition of the weight management.
Yes, absolutely. So we know that if we can get weight management, the foundation for type 2 diabetes is always going to be diet and exercise. These therapies are in addition, and these therapies, if they can help with diet and exercise, they're very beneficial.
A quick question. So have you had a situation where people are so excited that they're on certain drugs, but maybe they want additional weight loss or just to skirt some of the diet and exercise?
So yeah, definitely, you can see the mechanism of the medicine of the GLPs. What it does is slow down your gastric emptying. When they studied the medicine, what they found is with type 2 diabetes, you kind of always feel hungry. So that satiety is not really there. So another mechanism of how this medicine works is it works on your brain, and it allows your brain to stimulate that you're full quicker. So yeah, there is a tremendous benefit. Now, as providers, we look at the patient profile. We're not looking at just why you want this medicine. We've got to look at whether it's beneficial for you. And when we get those patients in those lower BMIs, is this the best medicine for this patient? Maybe not. We have to look and see, what we can do.
There's all things to consider, looking at what the patient has and their medical history. Some of these medications aren't appropriate for certain patients if they've had certain complications or if we see them as a higher risk to developing complications. With the weekly gut hormone injections that we have on the market that help that can help with weight loss and blood sugar control. It does impact how the GI system functions. It can, as it slows it down. So if you have somebody that deals with a lot of GI things outside of their diabetes, then this might be something that could complicate that. So we do always want to have that discussion with the patients so they're aware of most common side effects and go forward with the decision together on whether or not we trial it or not.
Mm-hmm.
Now, maybe I missed something, but just to clarify, those medications, are they mainly for people with a type 2 diabetes?
So they are FDA indicated for type 2 diabetes. Semaglutide is also have an FDA indication for weight management. However, it is marketed under the name Wegovy. So a lot of times, that is the only FDA GLP that we have besides Saxenda. Saxenda is a GLP that is FDA approved for weight management, but that's a daily injection.
And when they did that drug study, they didn't look at a specific patient population with type 2 diabetes. So it doesn't have to include the patient population of type 2 diabetes. So we can use it in the general population if we're using it for the indication of weight loss. And that can include a type 1 if we're looking specifically for that indication with Wegovy versus Ozempic. Ozempic is a brand that's just specific to the indication of type 2. So if we used Ozempic, it would be off-label because of that.
I know. I have had people ask me questions about that, so that's all I need to ask.
Yeah.
So I think we've kind of discussed on what the new medications and how we usually treat them and manage them. So the popularity seems to be with is it the once a week or
the once weekly injections.
The injections.
Yeah, they have very good uptake, very good results. As far as from a diabetes standpoint, we can get pretty good glucose control, if not at goal, within several months of starting therapy. Now, the side effects of the medicine can be nausea, stomach discomfort. So there are medicines that patients can't tolerate, and then that's when we reach for the other medicines in that class. So we look at the class, and then we look at each specific molecule.
Sure.
So then, approximately how many, aside from the shot, you would need other medicines that complement that or assist?
Depending on the patient response with their blood sugar control, sometimes we can just have a patient on just one medication and it'll lower their A1C within goal, and we'll see a lot of positive results. When you're looking at type 2 diabetes, it's a progressive disease, meaning over time it's going to get worse. If we see stable blood sugar control in the beginning of the disease process, we're likely going to be able to have a slower progression to where somebody's going to need multiple medication therapies or insulin later in life. So we do have patients that we just have on these types of medicines, and it's just a once weekly, and it's doing things just fine and keeping things stable. Over time, we of course monitor our patients closely, and sometimes we have to add on something in addition to that. We do pair the SGLT2 drug class with the GLP drug class together because you have a lot of extra benefits with the heart protection and the renal protection, and they can be used together. So it's kind of something that we just gauge with our patients monitoring their sugars, making sure that they're relaying to the office if they're having concerns for high sugars between appointments, and then we can adjust things, even between the time frame that we see them face to face if they're having issues.
And if they are on those medications, are they administering that themselves, or do they have to come in the office?
They do it at home themselves. Usually they come in auto-injectable pens, so it's very convenient for patients to be able to do this at home. And then just to kind of add on to what Annie was saying about, different medications and regimens and things like that, one of the biggest factors is cost. Even though these medicines are extremely effective, they can be extremely expensive too, depending on what insurance plan you're on. especially now, just a disclaimer, because it's getting to be the fall season, different Medicare supplement plans pay for your medications differently. So definitely, if you are a diabetic patient, you want to be looking at your policies when you're selecting them and trying to make sure that they cover these more expensive medicines, because as we mentioned multiple times, you get more benefit from those medicines. So when we look at different regimens for different patients, it could be that we chose this for you because it's more cost effective for you, and you're also going to get benefits.
So as a person who's setting up a lot of insurance enrollment programs right now,
Oh yeah.
check your formularies.
Yes,
Make
please,
sure across
please.
the board it's going to cover the majority of the medications that you're on the best way. That's most important for sure.
And that's another benefit of coming to Reid Endocrinology and kind of seeing, as we do have quite a bit of access to the manufacturers as far as patient assistance programs, you know, through that. And then we also have copay coupons, different things like that, resources that we're able to navigate for patients.
And since you mentioned that, can you explain patient assistance program?
Yeah, so typically, just as a general rule, a lot of manufacturers of medication have available patient assistance programs. They are for Medicare patients, and you do have income requirements, and it's different for every you know, manufacturer. So go to that manufacturer website. Usually they have a lot of good information. If you're one of our patients, don't hesitate to call the office or send us a MyChart message. But yeah.
Yeah, because we have somebody in the office that dedicates themselves to just patient assistance to make sure that that process is being filled out correctly and there's a follow-up on it. Generally speaking, once the paperwork is completed and we submit it on the patient's behalf, it can take 3 to 4 weeks to even hear back from the pharmaceutical company. So it's a lengthy time wait, but the benefit is that if they are approved, then they're approved for that next 12-month period of time, and they're going to get their medications free to them. So as far as a patient access viewpoint, that's amazing because these medications are expensive if insurance is not going to cover them or the patient doesn't have the financial means to take care of them or to buy them rather. Then once a patient is approved for patient assistance, going forward, they want that application to be renewed on a 12-month basis just so the pharmaceutical company knows that the patient wants to remain on the program. And often what we see is if you're approved for the first year going forward, it's usually pretty flawless, flawless system. But yeah, so we do spend a lot of time with that. We also spend a lot of time with insurance prior authorizations because sometimes insurance companies want the treatment plan to be stair-stepped into these more expensive medications so we can navigate that whole process.
And that's so important. I don't think people in the general public, until you actually need certain drugs, have no idea that it's not that the provider or the hospital didn't want to help you, but it can be very cost prohibitive. And so just educating people and coming in. I know when I first started, I was doing more insurance things, and it was amazing because I said, why do we need all this? And then once I started to see how much the actual insurance was, not the insurance, the actual
Paperwork.
not as well as the medicine, the medications.
Yeah, for sure.
I was really taken aback. So just by educating people and making sure that when they come to your office, they see the different people in each office that can try to assist you is so important.
It's always good to have it's a team effort by any means, and we're their support team for a lot of different things.
And when you were back on with the insurance coverage, and we've discussed that, but a lot of times I know within companies itself, some companies will not cover any in certain medications, and some will. So
Yeah,
we also
we-
have to look at that.
Yeah, we do see that a lot sometimes with the weight management specific medicines that we talked about. Sometimes they're excluded from insurance policies. So I think a lot of times, what we ask patients to do is kind of contact your insurance and figure out what they will cover for you, and that sometimes saves them some heartache as far as us sending something in and then it not getting covered and just that frustration standpoint, because what we want to do is help them,
Sure.
and if we have the right drugs on board, then we can do that more effectively.
Because that's why you're providers. You want to assist
That's right.
We so how do people contact you?
Definitely for our patients, My Chart's always a very good tool. If you don't have that set up, you can call the office. We'll give you a code. That's always a good thing. And then also our phone number is 765-935-8941. We are there Monday through Friday, I think 8 to 5.
Yeah.
And your office is then what's considered our medical office building at Reid.
Yes,
So
on the third
it's
floor.
to the right of the main entrance. No,
Correct.
to the left of the
Oh,
main
yeah.
entrance. I'm looking backwards here. And before we close, was there something that you would like our audience to know? One last thing that you would like them to know about Reid Endocrinology?
I think Annie really hit it on the head when she said that, it is definitely a team effort and we are definitely with you on this journey. Diabetes is not easy to manage. Diabetes can be a very frustrating disease process. As Annie mentioned, it's very progressive, so just because a treatment plan's going well doesn't mean that it's always going to go well. So that's why we like to see you in the office, and please know that if you have questions or concerns, we're always there to help. Definitely, I love having Annie as a coworker, but as I mentioned before, we have Dr. Crutchman and Natalie King as well.
Yes, and they're excellent.
And I think our team's amazing.
Yes, we're very fortunate. We have an excellent team. Everybody's main goal is to take care of patients and be their support network. So we're very fortunate to have that here in the community.
Well, thank you both for joining us, and thank our audience for joining us in this episode of Let's Talk Together.
Let's shine by seeing the best in all of us and by looking out for each other. Let's stay healthy. Let's shine together.